Hello and welcome back. This is Dr. DeChavo. Moving on to chapter 14, which is sensory function. The book that we're using lumped the aspect or thought of sensory input in with special senses such as eye, ear, etc. So we are going to look at both, which is part of the neurological system, including cranial nerves. Don't forget, I'm going to give you some cranial nerve reviews and how we actually sense and feel our environment. Let's get started. So, general senses, how we feel the world, include pain, touch, pressure, temperature, and I think the only one you probably don't find familiar is proprioception. Proprioception is our awareness of where we are in space. So, for example, you're driving and you've left something in your purse or your bag in the back seat. You move your arm behind you. You know exactly where your arm is going, even though you can't see it, because of proprioceptive receptors. And those are found in the joints of the body. So, we're going to look at those more specifically in a slide or two, but we also are going to review taste very briefly, smell very briefly, sight, hearing, and balance, because this is all part of that sensory system. So here's a general overview of both of them, and normally I don't get too heavy into sides, but I do want you to know the generalities of this slide. So they've broken it down into general senses and special senses. Now with general senses, the two main groupings that we're going to look at is naked nerve endings versus what are called encapsulated. When we look at temperature and pain, these are naked nerve endings, and what that means is they do not have any connective tissue around them encapsulating them. They look almost like the branches of a tree, and they'll come up through the skin, through the dermis, all the way up to the epidermis, and they will sense pressure and temperature. Pain and temperature. The reason that I always remembered this is because these naked nerve endings are naked and they are ready to immediately sense painful stimulus so we can get away from it, or temperature, which is interesting, but if you think about it, if you become too hot or too cold, it becomes painful, and we need to monitor that level of heat or cold to make sure we don't become hypo or hyperthermic. The rest of these sensations, light, touch, pressure, both light and deep, and proprioception, are sensed by encapsulated nerve endings. And what that means is nerve endings with a little connective tissue around them. Proprioception may not seem familiar to you, so let's review that really briefly. Proprioception is sensory endings that are located in joints or muscles that allow us to sense where we are in space. For example, if you're driving and you decide that you want something from the bag in the back seat, you can reach back there, which is not good for your shoulder, by the way, but you can reach back there and your body knows where your hand is in space, even though you can't see it, because of these proprioceptive receptors. Now, special senses deal with taste, which we're going to review briefly, which is sensed on your taste buds, but you also need to know the cranial nerves for it. Smell, which is sensed on your olfactory epithelium in the nasal cavity. Sight is sensed on your retina. And we are going to look at the anatomical structures of the retina because the retina can detach because of its anatomical placement. And if it detaches in the back of the eye, I'll show you how that happens, you can lose sight. Hearing is sensed on the organ of Corti, which is in the ear. Balance is sensed on the semicircular canals, which is also in the ear. And we'll go over those anatomical structures so you know where things can go wrong if people have damage to those sensations. Now, sensory receptors include all of these, and they pretty much tell you what they are by their name. Mechanoreceptors are going to sense mechanical pressure. So touch, deep pressure, light pressure, and we actually sense all of those on different spinal tracts through the spine. So if you end up working in a pain clinic or for a neurologist, they may want you to know which ones go through which spinal tracts, because that helps you to so that mechanoreceptors may be important in the tracks for you to know if you're working with patients who may have spinal cord trauma, tumors, or herniations. Now, chemoreceptors are going to be stimulated by chemicals. We'll see this in the blood. We actually have receptors that monitor levels of oxygen, hormones, etc. We'll see it coming from food with taste, air with smell, to give you a few examples. Thermoreceptors will be activated by heat or cold. If they branch up into severe cold or severe heat, you can get into stimulating those nociceptors, which are those that are present for painful stimulus that we see at the bottom there. And I always remember nociceptors because they are stimulated by noxious stimuli, things that would create pain and or discomfort. Now, photoreceptors, easy peasy, those are going to be activated by light. Here's pictures of general sense receptors, and you can see at the top that we have these free nerve endings, and they'll actually branch up into the epidermis. And the epidermis is this top layer here, if you remember. Dermis is the middle. We can see there's sensory receptors interspersed through that as well, all the way down to the hypodermis. In general, I want you to know that nociceptors and thermoreceptors are free nerve endings. The rest are encapsulated, which means they have a connective tissue around them that will sense light, deep pressure, or the sense of touch. Pain, we know, is associated with many conditions, and it's put in place as a protective mechanism. Unfortunately, pain can become an issue because of damage to the structures of the body, as opposed to something that's, a response to your environment to a quick stimulus, such as heat or something sharp. We can actually damage internal structures that can cause chronic problems. So this is the most common reason that people seek medical attention. We deal with pain so much. It can be used to aid your diagnosis, so your type of pain, the location, whether it's persistent or not. The problem with pain is it's subjective, so it's very difficult to get a really objective diagnosis with these subjective feelings, but we do the best that we can, and the important thing is that we correlate it with other factors that we either A, examine, or B, test. Pain threshold's also a difficult thing because it's so subjective. So that's something, if you end up working in a pain management office, that you have to take in multiple factors with that pain threshold with a patient. Unrelieved pain can delay healing, can stimulate the stress response, which is a bad thing, and it can result in pain tolerance. Acute versus chronic, just to give you a bit of a definition for this, acute is going to be a short-term injury, a sudden onset, hopefully gets treated quickly, usually due to some sort of injury. Chronic is a long-term response to injury that's damaged the tissues. Your book has usually longer than 6 months. I've seen anywhere 3 to 6 months. So we'll put that time frame in there. Somatic versus visceral. So somatic will be something that damages skin, joints, muscles, tendons. This is easy to pinpoint for the most part, although you want to make sure, just from what I was in practice, that you have the patient actually point to it. I've had patients say they have hip pain and then they point to their SI joint. So make sure you have your patients actually point to that pain. Visceral pain is horrendous. This is organ pain, and this is usually some noxious stimulus to an internal organ. It begins as vague and diffuse because the swelling actually has to touch the body surface near it in order to stimulate those pain receptors. So quite often it's really painful at that point because it's gotten so swollen that it's actually pushing out on the external body wall. So this can also give us the referred pain, which will be a sensation in a distant location from the original organ. Some of the theories with that is there's vestigial nerves left over from the way the baby developed, because babies' organs actually develop very differently from how they are when they are grown. And they start in one area. For example, the testes in the male begins high in the abdomen. So testicular pain can actually refer back up high in the abdomen where they originally began. And one of the theories is there's some leftover nerves that correlate to those two areas because that's where they originally began. For example, kidneys start low and rise high in the torso. So one of the theories is that with that referred pain. Phantom pain is after the removal of a body part. The nerve pathway and the spinal cord nerves can still be stimulated even after that input has been lost. Intractable pain, I've always called this persistent pain. This is a type of pain when someone comes in and you know something is very, very wrong. They cannot get into a position or they cannot take a medication that will alleviate the pain enough that they feel that they can get rest from it. For example, I had diverticulitis years ago. I wonder if some of you cared for me. As a matter of fact, I had several nurses in and out. That was persistent, intractable pain. It was disturbing. No matter what position I was in, no matter how I laid down, you just can't get away from it. So that quite often means visceral pain, as opposed to intermittent pain, which a patient feels with musculoskeletal. If you have some sort of strain, you usually can get into a position of rest that will help it to feel better. Excuse me. As opposed to this persistent pain. This is usually a red flag. Neuropathic pain. So this is damaged peripheral nerves. It can be chronic and also persistent. This happened when I blew a disc. The herniation was so big, it was actually out into the intervertebral foramen where that nerve comes out to my low back. And because it was pushing on it so much, I had raging leg pain that was persistent or intractable. And no matter what I did, I couldn't get out of pain. So that neuropathic pain can also cross over into that persistent pain, depending on how much that nerve is damaged. Here's a chart of the referred pain or visceral pain that's felt on body surfaces. I won't ask you all of them. I think heart is a good one to know. It's also good to know that in females, heart can refer to the jaw. So I think we tend to think of heart as going into left chest, left arm, possibly left jaw. I've actually heard of it going into right jaw for females. That one, and I don't think they have liver and gallbladder. They have in the upper right. Liver and gallbladder likes to refer to that right shoulder blade, which they only have the front one. Those are the only two. Oh, and appendicitis. Right, McBurney's point, which I don't think I taught you. Most of you probably know that. But right lower inguinal region where you can get appendicitis referral. It'll actually start appendicitis around the umbilicus and go to the right lower quadrant. Those are the only ones that I want you to know. Liver, gallbladder, right scapula, appendix, right lower quadrant, begins periumbilical. You should know that. Heart to left arm, left chest. In females, it can go to right jaw. That brings us to question time. Referred pain is usually from a muscular injury. Referred pain is also associated with an underlying organ in that specific area. C is never an indication of a serious problem. D is visceral pain felt in an area other than the organ involved. Go ahead and answer that, and let's move on. 2 eyes. I see you. We're going to look at the structures of the eye. Here are the ones, there's a lot here. A lot of this I'm hoping looks familiar. Let's review them. Basically, the eye has 3 layers. There's a connective tissue on the outside that has the white of the eye, known as the sclera, and this covering of the eye known as the cornea. And the sclera and the cornea come all the way around and encase the eye and basically protect it. And it'll meld into the connective tissue sheath around the optic nerve. Now, the optic nerve is in the back. You should know that from examining the eye. And that location there are no sensory receptors. It's just the nerve. We'll get into all that. But that is known as the optic disc. That is also where blood vessels enter and exit the eye. Now, if we peel back that layer, I know you'd probably be grossed out by this, like the layers of an orange, we move down to the next layer. The middle layer, there's 3 layers we're going to go over. The middle layer of the eye is going to have the blood supply, which is located on what's known as a choroid. That choroid comes around and forms the iris and the pupil. They're all parts of the middle layer of the eye. And once again, the choroid is going to provide the blood supply to the eye, the inner eye, I should say, or part of it. Okay? It holds the blood supply. So these blood vessels come out and go into that choroid layer. Now, the ciliary body is also part of this middle layer. And all the ciliary body does is comes down, and it's the little muscles that connect to these suspensory ligaments that change the shape of the lens. Please note, the cornea is here. This is not the lens. Some people think it's the lens. It's not. The lens is deep. And the only reason I'm showing you the ciliary body and the suspensory ligaments is these are what are cut when people have their lens replaced. So that is all part of the middle layer. The inner layer holds the retina, and the retina will have the sensory nerves that will sense vision for us. And I actually have a better picture of the retina in just a little bit. Okay. Oh, and the lens. I forgot to underline the lens. And the cornea we went over. Inside of the back of the eye is this gel, and this gel fills the eye to make it round. It is called vitreous humor. And then we have very, very watery humor. Humors were the fluids of the body in the old days. Aqueous humor actually comes into this anterior chamber of the eye, which is in front of the lens. This is where it's created. And the aqueous humor will actually come to the entire eye to help feed and nourish structures of the eye. So this aqueous humor is the problem when we have glaucoma. Either we have too much of it or it doesn't get drained out. It's just like blood. It'll come in, nourish the eye, and then it needs to get out so we can get more fresh aqueous humor in it. So aqueous humor is the fluid that creates a problem when we have glaucoma. Vitreous humor is just like a gel. If you remember dissecting the cow's eye, which everybody loves to do, you cut it up. Some people do. Either you love it or you hate it. You cut the eye and that jelly comes out. That's the vitreous humor. Now, tear drainage, completely separate from aqueous humor. You'll create tears up here in the eye. They'll drain across the eye, and they'll drain out what's called the lacrimal puncta right here. The only thing that I could think of for this to know is you can put plugs in here if somebody has dry eye. And then we have the pupil, the iris, and the sclera from the front. Now the conjunctiva, or conjunctiva as some people call it, is a mucous membrane, and it'll cover the eyelids, come down, cover the sclera and the cornea, and then it reflects back on the bottom eyelid. And this is where we can put drops. You can pull that bottom eyelid out and put it in that nice little pocket there. And the conjunctiva is a mucous membrane to help protect the eye. And we're going to go over all these structures in the notes. I just really like giving you a visual. These are the nerves of the eye. So what is happening here is they're taking a little part of the retina and blowing it up. We're not going to get into all of these structures, just a few of them. And what basically happens is light comes in and it'll bounce off the retina and it comes back out. It stimulates rods and cones. You probably remember rods and cones from A&P. I have it in the notes later. Super easy. Cones are color, rods are dark. Okay, so the light will bounce off this choroid layer, come back, stimulate the rods and cones. Those rods and cones then stimulate the nerves in between, come back up to the surface, and then send nerves to the optic nerve. And then the optic nerve will go out the back of the eye. It's way more complicated than that, but for our purposes, I'm going to keep it that for now. So on the screen, you're asking what you need to know. You need to know rods and cones, and that light will pass through the retina, bounce off that pigmented layer of the retina, and back through the rods and cones to stimulate it and out the optic nerve. Here's those structures. Outer connective tissue layer has the sclera and the cornea. The middle connective tissue, or the middle layer that has the blood supply, is going to have the choroid, ciliary body, iris. You could say pupil if you want to. Inner layer is the retina. Some people also put the lens in here as well. I wouldn't ask you that. The retina is what responds to light and sends signals out to the optic nerve. The accessory structures components, we spoke about the lens, the vitreous, and the aqueous humor. This is important with the vitreous humor. It actually will push back on the retina and forward on the lens to keep them in place. The aqueous humor, I respectfully disagree. It goes to the anterior and posterior cavity of the eye. And then optic nerve transmit impulses from the retina to the brain. We've got all of that. So let's look at eyes perceive the environment. We've gone over most of these structures, so I am going to go through them quickly. So perceive the environment. Sclera is that white area. I wouldn't say lens, okay, because you're going to get confused. The cornea is separate from the lens. Anterior surface covering over pupil and iris. Choroid is that middle layer. It contains blood vessels for those eye structures. It's closely adhered to the retina. Ciliary body is on the anterior part of that choroid. It has muscles which helps to shape the lens. And it also changes the size of the pupil. Iris is the colored portion. Pupil is the dark opening. Easy peasy. Retina is that innermost layer. It has photoreceptors. It's attached to that choroid. That's where it separates from when we have a retinal detachment. Has rods which will be activated in dim light. Cones will sense color vision. So we'll send all of the nerves. I showed you that picture, how light goes through the retina, bounces off, comes back through rods and cones, and sends information to the nerves, which will lead to the optic nerve. There's one optic nerve in the back part of the eye, which you should know from examination of the eye. And there's no photoreceptors in that space. That's where we get the blind spot of the eye. You probably did that little test in lab checking for the blind spot. That's where we get that. So the visual pathway is super complicated, but basically visual images are cast upside down on the retina. We send it back to the brain. It goes through many steps and it gets converted to right side up again. And it's sensed in the occipital lobe. The lens we looked at, transparent, it's flexible. Those ciliary bodies can change the shape of it so we can focus the eye. Anterior chamber in front of the lens, posterior chamber behind it. I'm going quickly because we went through this. Aqueous humor is that watery fluid that goes into the anterior and posterior chamber, brings in fresh nutrients, takes out waste. So your vitreous humor is that clear gelatinous material that fills that posterior chamber. Your conjunctiva is the membrane that covers the eye that is reflected onto the eyelids, which we spoke about previously. The lacrimal glands are the glands that create tears and keep the surface of the eye moist. Blinking the eye cleans the eye by sweeping the fluid and keeping the eye moist. Tears will drain into that lacrimal puncta that I showed you in the corner of the eye. And you can actually see it. I don't know why I find it a little fascinating. When you pull your bottom eyelid down, you can see that little opening that's towards your nasal aspect of your eye. Now, one thing that was not in your book that I think is important for you to know is the extraocular eye muscles. So this means the muscles on the outside of the eye that move the eye. The ciliary body are the muscles that will actually be right about here, a little further out, that'll move the iris in or out depending on how much light we have or whether we're in sympathetic or parasympathetic facilitation. They are named according to their location: superior, inferior, lateral, medial. And I would always give you reference if I were to ask you this on an exam. Like if I were to give you a picture and ask you to name them, I would always put a nose in here. Can't draw. So I'd put nose or nasal aspect, okay? So rectus means straight. Superior rectus is the straight muscle on the top of the eye. Inferior rectus is the straight muscle on the bottom of the eye. Lateral rectus is the straight muscle on the lateral eye. Medial rectus is the straight muscle on the medial eye. I also call these straight shooters because they move the eye according to their name: superior, superior, inferior, inferior, medial, medial, lateral, lateral. Now, there's two oblique muscles as well: superior and inferior oblique. They both move the eye laterally. Just listen to me and then you could write this down. They both move the eye laterally but opposite their name. Superior oblique moves the eye laterally but down. Inferior oblique moves the eye laterally but up. Let me say it again. Superior oblique, they both move the eye laterally but opposite their name. Superior oblique will move the eye laterally and down. Inferior oblique moves the eye laterally and up. Okay? Now, I think it's important for you to know these extraocular eye muscles because people can, A, have a weakness in them, creating drifting of the eye, B, have cranial nerve damage. You're like, oh no, not cranial nerves. Okay, I have a really easy mnemonic to remember the muscles that are involved. So if you end up going into a neurology practice, this is the mnemonic to remember. With the cranial nerves, we have 3 cranial nerves that help all of these muscles move. So we actually have superior oblique, lateral rectus, and ocular motor. Here's my silly saying. SO4, and this came from just a giddy study night, you know, where you don't think you can do another word of memorization, and we had to memorize the extraocular cranial nerves. My roommate, got to give her props for this, came up with SO4, LR6, the rest are 3. SO4, LR6, the rest are 3. What that means is superior oblique, superior oblique is innervated by cranial nerve 4, SO4. Lateral rectus is innervated by cranial nerve 6. Sorry, can't get this straight really well. The rest are 3, cranial nerve 3. So cranial nerve 3, when it comes out to these muscles, sends a branch to every one of the muscles I labeled 3. For some unknown reason, only God knows because he made us, or whoever you believe made us, he put cranial nerve 6 to lateral rectus and 4 to superior oblique. So if a patient cannot move their eye laterally and down, they have cranial 4 damage. If they can't move the eye directly laterally, which would be hard to test because you can kick in the oblique muscles, but anyway, theoretically, they would have cranial nerve damage to 6. All right, if they have trouble moving multiple directions, it could be 3. So SO4, LR6, the rest are 3. Superior oblique is innervated by cranial 4. Lateral rectus is innervated by cranial nerve 6. The rest are innervated by cranial nerve 3. Let me know if you have a question about that, but that's a quick and easy way to remember this. And that, my friends, brings us to, oops, there we go, a little let's practice. If you need a minute to look at these anatomical structures, pause the tape. Otherwise, I'm going to get right into it. 1 is the lens. 2 is the cornea. 3 is the sclera. 4 is the retina. 5 is the optic nerve. 6 is your vitreous humor filling the back of that eye. And that brings us to the end of this tape. I thank you. If you have any questions, as always and forever, shoot me an email. I'll see you in the next video.